الآن مع الجزء الثاني في how to reach diagnosis. Without a clue you will not be able to reach a diagnosis. فكل شغلك اللي حتسويه في الهيستوري والexamination you try to find a clue. A clue for a diagnosis. الكلو ممكن sign, ممكن symptoms, ممكن شيء في family history, ممكن شيء في اللاب. Without this clue, your life will be difficult. Be very meticulous. Do not miss small events في الهيستوري أو في اللاب result. Start wide thoughts, open thoughts, then limit your thinking to narrow pathways till you reach your final diagnosis or dysmorphology diagnosis. Try to find a starting point which is that may lead you to a diagnosis. مثل الجينيتكس أو الدysmorphology مثل أي جزء من الجينيتك من الميديكال field. It is history and history and history in addition to examination. So these are the two tools that may lead you to a diagnosis. Investigation or general lab investigation, it's also a helpful hint for your diagnosis في dysmorphology. لكن أهم نقطة بالنسبة لي أهم شيء بالنسبة لي في dysmorphology is what I call synthesis, and I will explain what is synthesis in the coming slide, and it is the main or the core or the major issue في البرزنتيشن حقتي اللي هي synthesis. It's most important consideration whether the patient his face resemble the other member of the family or not. يعني morphology of human being is variable. فأحيانا some of the features are common in certain population أو حتى عوائل معينة. فأحيانا تعتقد إن هذا الطفل عنده مشكلة وهو في الأصح he look like his family members, خالة, جدة, عمة أو أبوه أو أحد من أخوانه. مع إنه انتبه أحيانا يكون he look like somebody else in the family, مو معناه إن that means something is okay. Maybe it's these two people and family members have the same dysmorphology diagnosis. During history and examination, مثل ما قلنا, try to find a clue for a diagnosis. Try to make your mind, is this child have real dysmorphological features or have structural anomalies, and is it single or multiple anomalies, and try to classify it to the classification that we mentioned before, dysplasia, deformation, or malformation, as a sequence or syndrome or chromosomal or teratogenic. هذا الآن اللي بقوله هي التكنيكس اللي أنا أستخدمها which is very helpful for reaching diagnosis. الأولانية facial أو general gestalt, يعني اللمح, يعني من يوم تشوف الشخص أو الطفل أو تكون هذا عندك كذا لمحة, يعني حتى من بعيد أحيانا من يوم تشوف الطفل هذا تقول هذا look like child with Down syndrome. أنت ما فحصت لها, you didn't listen to the heart, you didn't look to the creases, you didn't look carefully, بس باللمح. زين, فالجنرال لوك أو الجشتالت مهمة جدا وهي tool for making diagnosis. فهي واحدة من التكنيكس باللمحة, هذا شكلك كذا. لما تبدأ من هنا تروح أنت هتأكد أو تنفي هذه المعلومة by looking for the features of the syndrome or the condition you thought about and try to see if it doesn't fit with your patient or not by looking to the history examination واللاب result حقاتك وتروح انت تقرا عن السندروم هذا what are the other features and try to see if your patient has it or not. Second technique is patterns of recognition. pattern recognition اللي هو يعني عدة أشياء مع بعض. هذه الأشياء مع بعض تعطيك يعني الحالة أو السندروم اللي عنده. يعني الشخص عنده مثلا انسفالوسيل وعنده بوليسيستيك كدني ديزيز وعنده مايكروبثالميا وعنده بوليداكتيلي. هذا الباترن ريكوجنيشن اللي انت شفتها او انت اكتشفتها وطلعتها it will lead you to a syndrome. زين في الحالة مثلا ميكل جروبر syndrome. ف trying to recognize these patterns it will lead you or it is a technique that lead you to a diagnosis. طبعا عشان تقدر تطلع recognize these patterns you need to be مثل ما قلنا meticulous looking for all the findings في الهيستوري في الاكزامينيشن and في اللاب results. Another third technique is a presence of rare abnormality. Something unusual. It's a clue or it will lead you to the syndrome. مثلا مثل ما قلنا encephalocele. It's not something very rare. Very few syndromes that has encephalocele. فإذا وجدت rare anomaly, try to find a differential diagnosis for this encephalocele, for example, and it will give you the diagnosis. Try to مثلا حصلت مثلا it's one of the possibility Michael Gruber. Then you go and look for the signs or symptoms that are present in that syndrome you thought about. Yeah. Cataract مثلا. It's something rare. It's not common في neonate. زين. Somebody who just delivered with cataract. Maybe it's a leading finding to the diagnosis. And so on. There is a few rare anomalies that can lead you directly to the syndrome. Sometimes examining other members of the family is a technique. يعني مثلا عندك somebody with craniosynostosis syndrome ما انت عارف وش هو ولكن فحصت اخوه او فحصت ابوه او امه ووجدت انه نفس الفيتشرز على عمر متقدم يعني اكبر من هذا النيونيت يعني. فانت احيانا can reach a diagnostic by examining somebody else in the family who is abnormal او he has interesting features. اخوه مثلا اكبر منه من 10 سنوات صعب انك to diagnose the child at neonate لكن لما تشوف اخوه على 10 سنوات ممكن you can reach a diagnosis. ايضا literature review وسيرش for يعني findings that you found in the history examination it can lead you to a diagnosis. It could be a textbook زين or a search engine or software مثل Bosom or London the Oxford Medical Database. These are commercial expensive software that can help you for diagnosis or the free online Mendelian inheritance in man database which has many syndromes and disorders. الجزء أو مثلا حتى في الجير reviews which is look like the Medscape or e-medicine article reviewing articles. الtool الأخيرة اللي هو follow up. You just follow up the patient and you may find a diagnosis in follow up. Some features become more obvious in follow up of the patient. مثلا child with hypotonic later on at عمر سنتين 3 سنوات you become obese and you recognize this is a Prader-Willi syndrome. أو مثلا somebody was small body built hypopigmentation and later on he developed aplastic anemia, then you think of Fanconi anemia. In your history, just collect information about these issues like maternal illnesses, diabetic mother, for example, habits like smoker or drug addicts, exposure of the mother to medication, radiation, infection. And by the way, radiation usually doesn't make problems with or doesn't cause congenital malformations. For example, dental x-ray doesn't make any difference. Even just X-ray doesn't make a difference, doesn't cause congenital anomalies. Even CT scan pelvis doesn't cause congenital anomalies. It may terminate or lead to miscarriages or abortions, and it may increase the risk of malignancies, but usually doesn't cause congenital anomalies. You need to collect information about fetal ultrasound, how many are done, and what are the results, and what's why it was repeated. And the second part is the delivery, gestational age, modified delivery, and the growth parameters. Apgar score. So you take the event, take the history as events. What happened? What are the events in the neonatal period? Was the child admitted to an ICU? Was he or she ventilated? What was the feedings? Why he stayed in the NICU? And what happened at 6 months and 10 years and so on. So try to divide the history as events, and these events may lead you to a diagnosis. It's important to get a postnatal developmental history and growth. As a geneticist, family history is an essential part of history. It's not enough to say to a mother, for example, are your children healthy? Or is there anyone with similar illnesses? It's not enough. You need to take a more detailed family pedigree. You need to take at least 3 generation pedigree and ask about miscarriages, which are not usually mentioned by the family members unless you ask. Keep in your mind the variability in expression in genetic disorders. So when we ask about this child and that child, other family member who may have a mild degree of your suspected diagnosis. The rest of my slide will be dealing with the examination. In reaching diagnosis, the diagnostic handles are variable strengths. As we mentioned, the major malformations are strong handles, while the minor, like the breast nasal bridge per se, may not lead you to a diagnosis. For example, just clipectomy doesn't help you, or doesn't lead you to diagnosis. It's weak handle, same like low nasal bridge or low ear, as in these photographs, this child, or rocker bottom foot, for example. So these are either considered poor handles. However, there is some good hands, even if they are minor anomalies. For example, these are Mongolia spots. It's considered a minor anomaly and can be normal in some population. But multiple Mongolia spots may lead to a diagnosis. Pigmentations, which are minor anomalies, may lead to a diagnosis. And also the hemangio, as in this chart. What I'm trying to say, try to choose good handles to reach a diagnosis. Try to address the child or the patient during examination. Do full examination and try to use measurements. The growth parameters, for example. There's a special measure within the face or the limbs. Look to general appearance of the child, especially the face and the eyes and the palate and the genitalia and skin, which are commonly missed in examination. The most important part of this morphology is the face, and the most important part of the face is the eyes, and the next one is the limbs, and the most important part of the limbs is the hands. Blind brain will be blind eye. You will not be able to see things if you don't have the knowledge and what to look for. So try describe the features. The mother can tell you that her child is different than the others. It's not enough to say this child is dysmorphic. It doesn't help you for reaching diagnosis. You try to describe what is in the face or in the child body or this adult man or woman is unusual. Should try to describe, build your capability and skills of description. and try to find uncommon findings there, which are the uncommon handles, which is can lead you to a diagnosis. And examining other members, and ask the mother to show you the photographs in her mobile. She showed you with the child when he was in neonatal period, or when he was 5 years, or his siblings. So if you cannot examine these people directly, just use the mobile. The photographs are very important at different age, other members of the family. And the rest of the examination is also important. The growth parameters, general look, head and neck, limbs, chest and heart, abdomen, genitalia, extremities, joint, back, skin, neurological examination are all very important part of the examination. And this is a slide about the importance of measurements. We have measurement for every part of the body, and it is published in this book. We have a reference measurement for each part of the body. For example, we can divide this limb to proximal, middle, and distal part. This is the upper arm, and this is the forearm. We start from a crown till the end of the humerus. This is the proximal segment, and from that point to the radial process is the second part, which is the middle segment. Proximal crease here in the arm until the middle finger, the proximal crease of the middle finger. This is the arm length, and the middle finger measurement is also the same things for the upper limbs. From the greater trochanter to the gap between the femur and the tibia is the proximal segment, and from the upper part of the tibia till the medial malleolus is the middle segment at the foot, from the heel till the big toe. The measurement both just circumference and internibal distance, and all of them have growth charts for measurement. Also the face, we can measure the palpebral fissure, the interpupillary distance, the outer canthal distance, the medial canthal distance, the nose length, the mouth length, the ear length, and we can all record it and plot it in a chart and see if it's abnormal or normal. And we can use these calipers or tape for measurements. And then you record them. Just make, for example, the upper limbs and lower limbs measurement that I told you. You can just make a table. Right upper arm, left upper arm, right lower limb, left lower limbs, then you write proximal, middle, distal, and you put them in numbers. And also record the weight, height, head circumference, intercanthal distance, outer canthal distance, interpupillary distance, palpebral fissure. Just record them in your notes. It's important to focus and try to look for a clue. As I said, without a clue, you will not be able to reach a diagnosis. What I mean by clue is looking for the abnormality, the uncommon abnormalities or rare anomalies or findings that may lead you to a diagnosis. It's important to look for evidence, and the sequence of events can lead you to a diagnosis. This is an example. This is not the child I saw at an ICU about 20 years ago, but I remember the case very well. I saw a child in the ICU has 12 volumes file, and I went through page by page until I reached the diagnosis. I was very meticulous and was reading what happened for the child and look for events. At the beginning, when I saw him, I thought it's subtle dysmorphism, nothing very specific. I didn't have the gestalt diagnosis when I just saw him. From reading, the child has poor feedings, swallowing. He has a recurrent fever, unexplained fever. They've been given a lot of courses of antibiotics, and he had shock-like pictures. And that information that lead me to a diagnosis. He has multiple shock-like pictures without explanation, without sepsis, just fever with shock-like pictures. And he noticed that he has camptodactyly, that means contraction of the fingers, and he was hypertonic, And when I search on, collect this information, and then I went to my books and tried to read and look for a possible diagnosis, and I came across a syndrome that I never heard about. It's called Crisponi syndrome. It's written here, Crisponi syndrome. From reading that syndrome, it said these children, when they cry, they tinge their mouth. They don't cry by opening their mouth. And I went back to the child and I stimulated him to cry. And he was exactly doing the same things described in the book. He doesn't open his mouth. And looking to this morphology now, I say now, low nasal bridge, upturned nose, thick L in his eye, long, well-growth, like whistling face, mouth. And this is the same here. It's L in his eye, thick, upturned, similar feature. And high forehead, broad forehead. By just recognizing a sequence of events, I was able to make a diagnosis at that time. And this was before the molecular studies. And there was no gene at that time for Crisponi syndrome. Now, I'm going to take you part by part until the end, and I will try to use these rare anomalies or pattern recognition or gestalt features during my examination. Body build and habits. So this is a small body build. This is a triangular face. Also, this is an adult or adolescent with triangular face, short, child, thin habitus, cylindrical. So these will give you diagnosis. It could be Russell-Silver syndrome, it could be 3M syndrome, but this is a recognition of a finding, growth restriction. Or this child, like obese child, especially truncal, or a tall man, which we call morpholoid habitus. So you recognize these habitus and you make a note of them and put them in your search for a diagnosis. By just look at this child is short. The disproportionate shortening, and you see a lot of skin folds here and here. Just by لمحة كده اللمحة. This is achondroplasia, mid-face hypoplasia, frontal bossing, and by just combination of the pattern of recognition, you just put the things together, the trident hand, the short stature, the mid-face hypoplasia, then you make a diagnosis. So this is by gestalt, and here by pattern recognition, combination of the finding, we can reach a diagnosis. For skull and head, this is skull, you need just inspect and palpate. Here, inspect, look for the hair distribution, shape of the head, any anomalies like aplasia or encephalocele. Palpate the sutures until fontanelle, take the measurements and record them. See if the posterior fontanelle is closed, open, is there extra fontanelle. Do the measurements as I said, and palpate the suture. This is just a review of the suture. You need to learn them. Face here, this is the back, this is the occiput, this is the forehead. The suture here is called metopic, and this is the anterior fontanelle. This is a right and left coronal suture, and the one in the middle is the sagittal suture, and in the back two sutures are the lambdoid sutures. So here another diagram showing this suture is called squamous suture, and this is another drawing of similar findings. These are the shapes of the skull. If the suture is closed, the head will grow along that closed sutures. This is a sagittal craniosynstosis, so the skull will grow like this along this closed suture. So it will be elongated, and this is elongated skull is called scaphocephalic or dolichocephalic. It's here. These are other shapes. This is the normal skull. Triginocephaly, that means the metopic closure, metopic suture is closed. So it's like triangle here. The skull is triangle and it's grooved. We can feel it. This is the one we just mentioned, scaphocephalic. This is the lambdoid, the posterior. The right lambdoid is closed, so the skull didn't grow in that area. It's restricted. So they call it plagiocephaly. This is another plagiocephaly in the front here because the right coronal is closed. This is a brachydactyly, that coronal are closed and the skull is growing along the left to right axis. So it becomes like brachiocephaly. This is Alexander scaphocephaly. This is the trigonocephaly, which you would say like a triangle. This is plagiocephaly. This one is restricted, is not growing because of the right coronal is closed. And this is a brachiocephaly. It's like a flat face and flat occiput, and this axis is long. Now, if it's multiple sutures are closed, then the skull can grow like a tower, so called toruscephaly, or it's multiple, like in this child, could be like a clever leaf skull, which can happen in some certain syndromes, Gracious syndrome. This is another drawing, which can give you the name of the syndromes that can fit. And this is also better in recognition. You have a child like this. This is a brachiocephaly, right? With mid-face hypoplasia and syndactyly, then you can say this is upper syndrome. Somebody has craniosynostosis, big thumb, then this is Pfeiffer syndrome. This is facial asymmetry and hypertolerism. Protruding eyes, facial asymmetry, and this is broad thumbs. And each one of them can lead you to the diagnosis. Now, the face, as we said, the most important part of the body is the head and the face and the eyes. The face is divided into three segments. The upper part is called forehead, and the middle part is called mid-face, and the lower part is the lower face. This is starting the root of the nose till the tip of the nose. This is the mid-face. And this is the letter of U that's showing you this is the mid-face. Now, this is, you can recognize the frontal bossing or micrognathia from the lateral view. This is a marked frontal bossing with severe micrognathia. Retrognathia and micrognathia are exchangeable. And micrognathia is like if somebody anatomical, you are examining the mandible or you did X-ray and it's small, while retrognathia is just descriptive, without being a mandible really small. It's just mandible is pushed to the back, but we can use both of them interchangeably. So this is micrognathia. This is a part of mid-face hypoplasia. This more marked. You can see it like this, mid-face hypoplasia, and if you see sometimes called dish-like face. The facial shape is important. For example, triangular face, flat face, myopathic face, like this child, broad face, elongated, whistling face, premature aged face, like in this child or this adult. And mid-face hypoplasia is a part of the facial shapes. This is a triangular face. This is protruding ears. Protruding ears may be large ears. This is also protruding ears. Wide open mouth, tinted upper lips, low nasal bridge, broad nasal tip, puffy looking eyes, sparse hair. Facial gestalt can just make a diagnosis by looking at this photo. This is child with Down syndrome. Maybe it's easy, sometimes difficult in some African people, especially if they are from South Asian population. But by gestalt, you can say this is Down syndrome. Even you can diagnose sometimes Down syndrome from far away by looking to them from at the end of the corridor, even from the back. While walking, you see, they'll say, this is child with Down syndrome. So gestalt, facial gestalt, or general look is a handle and a technique for a diagnosis. Another gestalt, this is a child with Down syndrome, this one. The propagnathia looks elongated face. Ears are not that big, but usually this syndrome is big. So this is a fragile legs. This one we just mentioned, we show his photo before. Short stature, rhizomelic, that means the proximal segment is short, mid-face hypoplasia, frontal bossing, redundant skin. This is a chondroplasia. Another one, can just say this is hypertelorism, crossing eyebrows, crossing eyebrows. You see it, then you look to the lens, you go to the heart, you make a diagnosis of coronary delight in this syndrome. This is hollow prosencephaly, probably with bilateral clefting. This is a premaxilla, flat nose, very small nose. Better recognition, you can just say, for example, this child's small body built, triangular face, maybe this is 3M or this is Russell Silver. Tall man with arachnodactyly, long arms, long feet, the wrist side, the thumb side is positive. These combination of better of anomalies or findings make diagnosis of Marfan. Even if you don't know what's the diagnosis, but you were able to recognize the arachnodactyly and the tall stature and these thumbs, and you put them in a search engine like Google, it will give you a diagnosis. In the eyes, there is multiple things you can recognize. You start from the eyebrows, the eyelid, the eyelashes, the conjunctiva, sclera, lens, retina, look for cataract, look for coloboma, look for the color of the iris, any telangiectasia, absent eyelashes, double eyelashes, and all are mentioned here. Not all of them, but this is what you recognize. That this is down slanted eyes, hypertelorism, apicanthal folds. This is how you measure. We take from medial canthus to medial canthus. This is intercanthal distance, and from outer canthus to outer canthus, this is outer canthal distance, and from the pupil, from middle to the middle pupil, this is intermediate distance. Or you take the palpebral fissure, and this is called palpebral fissure lens. Hypertelorism is increased interpupillary distance. That means both eyes are increased. That means the intercanthal and outer canthal distance and interpupillary distance are increased. Hypotelorism is the opposite. All of these measurements are decreased. Telecanthus is increased in the inner canthus distance, but the outer canthus distance is small. These are the photographs. This is a normal chart, all measurement, and you can plot the chart. And this telecanthus, you can see this medial canthus moved to the laterally, both sides, while the outer canthus didn't move. And this is hypertelorism. Both eyes had moved to the side. This is iris coloboma. Coloboma, by the way, it's missing part of, for example, coloboma of the eye is missing part of the eye. Coloboma of the retina is missing part of the retina. Coloboma of the eyelid is missing part of the eyelid. This is hypotelorism, although there is other features, but this is where I'm looking here, just in the eyes. This is apicanthal fold. This is telecanthus. This is the eyes, medial canthal moved, and there is apicanthal fold. This is hypertelorism. Both eyes move, and this is hypertelorism, and there is shallow orbits, ptosis. This is all the thick eyebrows, and this is a short nose, broad nose, upturned nose, long fulcrum. This is down slanted eyes. This is up slanted eyes. This is narrow palpebral fissures, crossing eyebrows, cosiniferous. Canthus and versus apicanthal fold. Apicanthal fold, like here, it's coming from the skin is broad here, then it's coming narrow. This is apicanthal fold. The opposite is coming from below, going down. So this is the broad, then it's coming down thin here. This is apicanthus and versus. If you have ptosis and distal moved calci. This is called phimosis with narrow superficial. For the nose, the nose is divided into three parts: the root, the bridge, the tip. This is the root, this is the bridge, this is the tip. And you have how they are mentioned here. And this is the columella. This tip of the nose is a columella. And this is short nose, low nasal bridge. It's clear here, no nasal bridge. And this is hypoplastic midface. This is low nasal bridge, wide nasal tip. This is hypoplastic LNSI. This is normal child. This is mild hypoplastic. This is clear. This is a clue. This is a rare finding. It's uncommon finding, as I mentioned, that can lead you to diagnosis. This is another nose, hypoplastic nose, LNSI. And this is the columella we mentioned is protruded. This is mid-face hypoplasia, low nasal bridge, broad nasal tip, upturned nose, and this is the narrow nose with the pointed tip. Each one of these can lead you to the diagnosis. This is upturned, this is very clear upturned also, mid-face hypoplasia. Thick LNSI, this is thick, the nostril wide open but thick. The nostrils are thick. Around it, thickness around it. Well-grooved nose with very small nostril with thick LNSI. Similar thing, mid-face hypoplasia. This is a bifid nose with hypertourism, which can indicate to a certain syndrome. Now we are talking about the ear. The ears has three things: position, shape, and extra structures. The position, you make a line between medial calci and extend it to the ear. You should have at least 1/3 of the ear above that line. Posterior rotated ears is you make a long axis from here and then you push it back till you reach the ear. This is one long axis. And then another axis along the ear, and this angle, which is clear here, should be less than 20. If it's more than 20, this is posterior rotated ears. This is the helix, this part. This one is antihelix, and the antihelix has multiple parts. And this is the tragus, this is the tragus, and this opposite to it is antitragus, and this is the ear lobule. The antihelix is divided to anterior crus. This is the inferior, and this is the superior. Okay, and this is the concha. Concha is the groove, the groove here and here, called concha. This is called cupped ear. The antihelix almost underdeveloped. This is protruding the ear. It's pushed forward. This is overfolded helix. This is called looped ear. It's similar to overfolded helix, but the shape of the ear is distorted, so it's more severe part of overfolding of the helix. This is the extra structure, so we should shape, position, and extra structure. This is extra structure. This is skin tag. This is microarchia. This is bits on the ear which can indicate some syndrome like Pickwick-Williams syndrome. These are important for that diagnosis of that syndrome. Now the oral region, so you have the philtrum, which is the space between the nose and the upper lip, and you look to the lip itself, the jaw. Then you open the mouth, look for palate. Sometimes you can see bifidobia, which is indication of mild degree of cleft palate. This is the bits we talk about, like the Van der Waals syndrome. This is a frenulum. This is a normal, but if you see multiple frenuli, it can be indication to some certain syndrome. Oligodontia, missing teeth with the frenulum of multiple frenuli. Macroglossia is an important sign to recognize, and also hypertrophic gums. Recognizing these findings and discovering them is a clue for your diagnosis. Shape of the mouth like a carved bow. مثل القوس، يعني يجي كذا طالع كذا ونازل كذا. Is a descriptive word for the face. This is whistle face. Microsomia, macrosomia, dentation, clifting, microglossia, hyperplasia. These are important. This is for Schwarz-Jampel. This is another syndromes. Now go to the neck. You just see short neck or webbing of the neck. Maybe you can see thyroid enlargement or brachial cyst, posterior hairline. For example, neck gestalt. You just look to the neck, then you make a diagnosis. Like in this shot, in this photograph, this lady is short and have webbing. But you go and look for the feature, the angle of the elbow, the interpupillary distance, and look for the history of the hair period and so on. So gestalt is an important part of redentition in the face and the neck or other part of the body. Now go to the lens. What to look for the lens? Can have brachydactyly, that means short fingers or toes. Clinidactyly, that means curved, lateral curvature of the digit. Polydactyly, that means extra digit, which is pre or post axial. Syndactyly, that means fused fingers. And the rest of the animals. Camptodactyly, we mentioned that means contraction of the fingers or digits. Arachnodactyly, long digits, broad thumbs, creases, abnormal creases, single creases, nail morphology like hypoplastic, hyperconvex, dysplastic nails are important for finding. This is the limbs anomalies, which is major, which can be like as severe as in this chart. Emilia, that means absence of the whole limb. Or phacomelia, that means missing proximal and medial segment and the hand as it's been attached to the limb, to the shoulder directly. This is called phacomelia, either in the upper limbs or lower limbs. Now to classify the shortening of the limbs. When you look to the limbs, look, are they short or not short? Then look to the joint. Are they contraction or hypermobile? If there is shortening, then you try to classify them or characterize them. Either as rhizomelic, mesomelic, or acro. That means proximal, middle, or distal segment. This is proximal shortening. This is middle shortening. And this is distal shortening, which is usually brachydactyly per se. This is another diagram showing you what we mean by this is rhizomelic, this is mesomelic, that means on the middle segment, or the distal segment is here acromelic. This is short arm, this is rhizomelic shortening the legs. This is mid-segment shortening, that means the arm, the forearm and the legs are short, or like this in this photographs also is mesomelic. Or acromelic, see the hands and feet are small while the arm and the forearm is okay. If this limb itself is all segments are short, called macromelia. It's not just single segment, and you can see here multiple skin fold, and this is head face hypoplasia and shortening, extremely shortening of the limbs. Even the whole body is short. Can say no elbow amputation, or you can say this is forearm emilia. This is brachydactyly, that means shortening the fingers. Polydactyly divided as post-axial, that means the digit, extra digit is in the lateral aspect of the hand or foot. This is called post-axial. If it's in the thumb, this is called polydactyly. Okay. Sometimes it's digitalized thumb like this. This is digitalized thumb. Looks like a digit. It doesn't have. It has 3 bones instead of pharynges instead of 2. This is double. We can say this is pre-axial polydactyl. We can say broad bifid thumbs. But it's the right description is pre-axial polydactyl. This is the real life. This is
post-axial polydactyly. Okay. Always try to count the fingers and toes. Sometimes you cannot recognize them without counting. This is pre-axial. It's like extra digit here. This is camped. This is the contraction of the fingers. This is broad thumb. By recognizing it, you can reach a diagnosis of which type, for example. This is syndactyly. When you describe syndactyly, you mention the toes are involved. This is, you can say, partial, second and third syndactyly, bilateral. This is arachnodactyly, no digits. Syndactyly, as we mentioned, you just mentioned the fingers are involved or the toes are involved. Sometimes the recognizing, for example, this child, as these lateral fingers are syndactyly, it can give you diagnosis of oculodentodigital syndrome. You can recognize it even before the teeth are not. Limb dysmorphology, radiology is very important for reaching diagnosis. As you know, the bones, the long bones, are divided 3 parts: the epiphysis, and the metaphysis, and the diaphysis. Adults, they don't have the epiphysis admitted because they are fused. So the epiphysis and metaphysis are fused, so they are 2 parts: diaphysis and metaphysis. One in children, this is the epiphysis, and this is the metaphysis. The epiphysis, metaphysis. I'll show it in a better diagram. This is what we may talk about. This is the epiphysis. This part, this big part, is the epiphysis. This is the tibia. Well, this is the femur. This is tibia, and this is the epiphysis. This part is the metaphysis, and this part is diaphysis. And this is patella. This is another showing. So diaphysis, metaphysis, epiphysis, and the area, the groove between the epiphysis and metaphysis is the growth plate. See it like this. Okay. And this is another bigger. This is the epiphysis. This is not normal epiphysis, well-formed epiphysis. Like this is a growth plate. This is the metaphysis. Okay. This is a spine. This is abnormal spine. Almost you cannot see the vertebrae. They are flat. So let's spondyly. This is epiphysis. We show you the normal epiphysis. This is irregular epiphysis. So this is epiphyseal dysplasia, as you see it. Now you see this one is the metaphysis abnormal, broad, irregular. This is metaphyseal dysplasia. So this is spondylo, this is metaphyseal, so epiphyseal. Sometimes some people, they have all of these divided. So you call spondylo epimetaphyseal dysplasia. And this is the normal spine for comparison. This is the spine again, lattice-spondyly, flat vertebrae. This is the normal. This is pointed vertebrae with sclerotic upper and lower vertebral plate. This is a very narrow chest with short ribs, and it can lead you for the diagnosis. Mentioning you all of these findings, try to pick them up. A rare anomaly finding can lead you to diagnosis. For example, you just see this rare abnormality, increase bone density, then you can diagnose osteopetrosis. Then you look for a bicap. If it is normal, this may be one of the malignant osteopetrosis, but if it's low, then you have anhydrotic carbonic anhydrase deficiency. So this is a rare example of a rare abnormality. It's tool or technique that can lead you to the diagnosis. Another rare anomaly, you recognize the rhizomelic. You did the X-ray and we see this mutual calcification, and you can make a diagnosis. Contradictoria punctata, for example. Another thing, you just recognize broad thumbs. Like this face, columella is elongated, and the eyes look like this sharp. It has congenital heart disease. They make a diagnosis for which type. Better recognition. You recognize this child has mid-face hypoplasia, tinted upper lip, down slanted eyes. He has chronic cystosis, and severe syndactyly. by recognizing the pattern of by recognizing this pattern, can make a diagnosis of Apert syndrome. Now to the joints, as I said, told you at the beginning, you can look for contraction or hypermobility of the joint. Look for petrigio. This is called petrigio. Can lead to diagnosis of hypermobile joint. Can find in Ehlers-Danlos syndrome or contraction as in arthrogryposis. Chest, abdomen, genitalia, and the back are also part of important. This excavatum, carinatum, broad, shield-like chest, abdomen, like organomegaly are important, polycystic kidney, omphalocele, or gastro cases. All these are important to recognize, as well as the genitalia, absent anus, anal stenosis, replaced anus, ambiguous genitalia, hypospadias, and so on. After you examine the child, you can recognize this syndrome if you recognize the findings. You have a child with a small head circumference, microcephaly, small eyes, microcephaly, microphthalmia, and you look at the genitalia, micropenis. This is called a micro syndrome. If you just put them in a Google, you can reach a diagnosis. Caudal regression. Just say the spine is not growing, and you see this abnormality in the lower legs, as in diabetic mother. This is caudal regression. Spine is not formed here. Distal part of the spine. This is effect of diabetic mother. You can compare this child, big baby, with the normal child. You see hyperplasia of the thighs, hyperplasia of the femurs are part of anomalies in diabetic mothers, infant of diabetic mothers, like congenital heart disease and caudal regression. If you see this anomaly, for example, omphalocele, it can lead you to diagnosis. It is a technique, is a tool to reach the diagnosis. So you think, if you see this omphalocele, then you go and look for other sign of Beckwith-Widman syndrome. Large tongue, hypertrophy. This limb is bigger than this one. Nevus flammus, creases. This is a crease here, or maybe it's better here. It's clear here. Crease or dimples sometimes in the back of the ear. Sure, a little bit of corsal with the face. Loin a braid, a nevus flammus. This is a Beckwith-Widman syndrome. You can recognize better of anomalies. These children have cleft palate. This is bifidiophila, polydactyly, abnormal genitalia. Then you can't make diagnosis with limb elvis. See the variability in the face. You may not recognize them by dysmorphology, by the face. Maybe you cannot recognize them by facial gestalt, but you can recognize them by pattern of anomalies they have. Similar here, pattern recognition. Narrow chest, extremely narrow chest, and you think this is normal? Yes, no, it is a polydactyly. Or did the X-ray? She see short ribs. We can make diagnosis of joint thoracic dystrophy. Examining the back, look for tuft of hair, scoliosis, and so on. CNS examination is important. Tone, power, ataxia, abnormal pigmentation, nystagmus, high cerebral functions. Skin examination is important. Hair, skin, nails. For example, here you can see redundant skin, hypoplastic. This is hypoplastic nails, or deep set nails. This is dysplastic nail. Abnormal pigmentation can lead you to diagnose hypopigmentation, hyperpigmentation, cutis or alopecia, hirsutism. All can lead you to a diagnosis, or can be part of a syndrome, or can be recognized as part of a pattern of a syndrome. Rare anomaly like ichthyosis, somebody with congenital anomalies can lead you to a diagnosis, and also like this hypoplasia, nail hypoplasia. See somebody with polydactyly, nail hypoplasia, the heart anomaly, will make the diagnosis of any spine cradle syndrome. Then you look to examine the mouth and so on. This is the one I talked to you in the spine cradle. So multiple frenulae, polydactyly, and congenital heart disease, then you make it a diagnosis by recognizing symptom. These are the 4 areas are usually missed during the examination, and I mentioned them already before, but I just re-emphasizing it. Several people forget to examine the eyes inside. They miss glaucoma, cataract. If you cannot open the eyes, ask the ophthalmologist for ophthalmological examination. Look to the mouth, even if the child's ventilated. Look to the palate. Look for anomalies in the gums, frenulally, the tongue, the palate. Examine the genitalia. Frequently missed. Sick child, nobody touch him. Nobody looked at the genitalia. It can be anterior placed anus, or even anal atresia with the fistula, and you can miss it. Examining the back. Child is sick, nobody is turning the back and looking what's there in the back. Okay. Now, we did the facial gestalt, we did the pattern recognition, and rare anomalies. Now, examining other member of family is important. Another sibling, you see this pigmentation. Or examine the mother has this pigmentation and this pigmentation, which can lead you to tuberous sclerosis in a child with epilepsy. Father, for example, has these fibromas, which can lead you to neurofibromatosis in a child who just delivered with hyperpigmentation. Some metabolic disorder, inborn errors in metabolism, can have dysmorphism. So which can make it, there is overlap between clinical genetics, dysmorphology, and inborn error metabolism. And there is similar disorder that can result with dysmorphism, like peroxisomal disorders, they wake up. Children in this group, they look like Down syndrome with severe hypertrophy, pyruvate deficiency, epileptic aciduria type 2, or like also like Down syndrome. Mucopolysaccharidosis by itself, they have a lot of dysmorphism, in addition to the skeletal findings. Now, if you cannot reach a diagnosis, or you've collected these findings, you need to go and research for a diagnosis. Okay, so you need to search and use software, use your online search, internet, to reach a diagnosis. Subtle dysmorphism doesn't help. Without a clue, it's very difficult to search. You cannot search with no clear findings. So if you cannot find anything in your history and your examination, there is no clue, nothing, you will not be able to get diagnosis. Maybe your molecular tests may help you, but in my experience, if you cannot find things in your examination and history, your molecular tests rarely give you an answer. Where to search? Most of the time, your history examination may not lead you to diagnosis, especially if you are not experienced. So use these electoral research. Go and put your findings in Google. Put, for example, hyperthyroidism, congenital heart disease, hypospadias, and write next to it syndrome or for gene. And read these findings until you find a good article that you review the topic about hyperthyroidism, for example. Syndromes that can present with congenital heart disease and hyperthyroidism. Look on PubMed, online, peer reviews, books, computer programs, and ask your colleagues. Try to build your search strategy, your keywords. Avoid minor findings in your search. Putting lucid ears or known as a bridge, it doesn't help you in searching. The same things for developmental delay is very common in many syndromes, so it doesn't lead you. Use these softwares if you have it, Oxford Medical Database. What you do, just a program divided to two halves. Here the collection of or list of findings, and try to pick the findings that is present in your patient and put it in this category. For example, your patient has microcephaly and also cleft palate. We put it also here. Then you did search for syndromes with these two findings. You hit OK, and it gives you 26 syndromes, and you go through them and see which one does fit with your patient, for example, here. And over them, and look to the photos. Does these photos look to your patient? Then you can make your diagnosis of corneal deland, for example. This is a helpful software. Same thing for Bosom, and Bosom has an advantage, it's more strong search for skeletal dysplasia. The future of dysmorphology is the artificial intelligence dysmorphology. Probably you will put the features and the photographs of the patient in advanced artificial intelligence machines, and they can give you a phenotypic diagnosis or clinical diagnosis. So these artificial machines maybe later on work as electronic dysmorphologists. And now there is software, for example, face to gene software. It's using the same things and trying to map the face and give you facial gestalt, and by putting the congenital anomalies you have in your patient, then it can give you a list of differential. And now they are using these deep gestalt technique to automated clinical dysmorphological diagnosis, and probably this is the future of clinical dysmorphology. It will not replace the dysmorphologist, but it will make it their life easy and give them a big differential diagnosis, and draw their attention to syndrome that they couldn't recognize quickly at the beginning. After you make diagnosis, you do the review. Now, searching for the diagnosis, you just put Google. Use the Google. Put the keywords or the key findings, or search for syndrome. Look to the photographs in the Google. Does it look like your patient or not? Use OMEM, which is an excellent free database of genetic disorders. MedGene is very helpful. It's part of the PubMed or the National Library of Medicine. Just put, for example, Marfan syndrome here, as I did here, and it just lists you, make it categories: clinical characteristic, additional description, clinical features, guidelines, suggest reading, reading clinical study, and so on. And it will be interlinked with OMEM, G reviews, and others. So MedGene is an excellent starting point for searching for information. G reviews is another part of National Library. Sometimes you can find good review articles what these syndromes that here came to your attention. PubMed is very helpful. Also, this is a helpful website, NARC initiative. Just put diagnosis here. For example, I put Marfan syndrome, then it will give me phenotypes, another differential diagnosis. Give me genes and correlated genes. It builds your differential diagnosis. Very helpful website, and it even lists you which system are involved. It's helpful for building your differential diagnosis. For example, you thought of Marfan syndrome. It's Marfanoid stature habitus, And you are looking for other signals that can give you morpholoid features. For example, I had this link, and this is the genes that can give you morphine or morphanoid syndromes. This spread syndrome, the various morphine with chromocystosis, for example, Lewis disease, congenital heart disease, characteristic congenital heart disease, and so on. Now, if you couldn't find diagnosis by gestalt or pattern recognition or rare anomaly, or you did, by examining the family members, and you did search and you couldn't find the diagnosis, just follow up the patient. You may find the diagnosis. And there is many times you can make a diagnosis and follow up, or just looking for previous photographs of a child, or the facial feature may change with time, or may develop the new findings or new symptoms. For example, this child just delivered hypotonic, and you don't know what's the diagnosis. You have no clue, and later on you develop obesity when you see diagnosis of Prader-Willi. It's another child, small body belt, hyperrotation, microcephaly, and you didn't know what is the diagnosis. Later on, you develop bone marrow failure, and this is coronary anemia. Then you plan. After you did, you recognize these findings, then you plan your investigation. If it is you are thinking of chromosome disorder, you carry do either karyotype or FISH, or you can do your biochemical investigation or molecular investigation as CTH or WIS or whole tumor, or radiological, renal ultrasound, abdominal ultrasound, skeletal survey, brain MRI, CK level, and other investigations based on your differential diagnosis. It's important group of patients not to miss stillbirth or near death, fetal death. You don't just say things are finished. No, sometimes these are tumor disorders and have future pregnancy mortals. We need to collect photographs of these patients, take enough samples, do skeletal survey, and if it's possible, to have somebody to examine these organs if it's allowed. So stillbirth and neonatal death are important to examine, and not to forget consulting a dysmorphologist. And if you don't have a dysmorphologist, take a DNA sample, EDTA sample like CBC, and keep it in the lab for DNA extraction to do DNA studies, or hyperanalyze, and also hyperanalyze for chromosomal studies, and take photographs of the patient.